Good evening, friends. Welcome to RSSDI Diabetes Bytes. We have two heavyweight champions today, and that's only for the topic in at hand. It's a very difficult topic, much less talked about, and a highly relevant one. So we welcome you, and this is with our ongoing Women and Diabetes series, where we have two really stalwarts from the field who are not only extremely busy, but both of them have taken the time and effort to be here with us today just so that a lot of these queries can be answered for the benefit of our audience. And they both believe very strongly in patient education. So, with that, I take this privilege and honor to welcome our very own RSSDI National Treasurer, Dr. Sunil Gupta sir, who's also the president of DIPSI, or Diabetes in India Pregnancy Study Group, and Dr. Uday Thanawala sir, who's the national chairman of ICOG and also the governing council member of DIPSI. Now you all can understand why am I so nervous today, because I have to, question these two stalwarts on matters of diabetes, pregnancy, and infertility. But let's get ahead, because today is holy and a very pious day for all of us, and we'll get moving with our discussion today. So, welcome to the show.
Thank you very much,
Thank you. Thank you, Purvi.
Thank you, sirs, for making time for us on such short notice. And RSSDI, the social media team, remains extremely thankful to you for the same. With that, the first question I would like to ask whether, what is the impact of type 1 diabetes as well as type 2 diabetes on male and female fertility? And why do we need to discuss this today? What is the importance of this situation, sir? Dr. Sunil Gupta, sir.
Purvi, uh, type 1 diabetes as well as type 2 diabetes, we should understand two important things. One is that any person with diabetes may be type 1 or type 2. They have little delayed menarche, that their menses comes little late than the common other girls. That's one thing. Second thing is they might get the problem with the ovulation if their blood sugars are not very well controlled. The third part is female with diabetes may even get the menstruation little early versus the non-diabetic women of the same age or maybe the same family. So these are few important parameters because of which the type 1 diabetes especially may get little issues on these lines. The second part comes as type 2 diabetes because of obesity, because of polycystic ovarian diseases. I feel that has been covered earlier. These women may have very irregular cycles, and because of that, again there is a issue of infertility due to hyperinsulinemia. I'm not going to go in detail because it's a public awareness program, but certainly even type 2 women with obesity, hyperinsulinemia, polycystic ovarian disease, with or without diabetes, even pre-diabetics, so even these women might face problem at the time of ovulation and the fertility. So both sides, hyperglycemia itself can affect the fertility. With very good blood sugar control, you can achieve wonderful, wonderful conception, wonderful healthy baby if you keep the blood sugar control from the day one of conception, not from the day one of diagnosis, as well as throughout the pregnancy. You can certainly achieve and get a wonderful healthy baby for the outcome as well as in the future. So that's one part. When it comes to, there's another issue which I feel you must never have discussed this on this particular platform, is double diabetes.
Hmm.
Double diabetes is type 1 diabetics becoming obese. So type 1 diabetics, already diabetic women, already is having compromised fertility issues because of ovulation, uncontrolled diabetes. Now you have also the features of insulin resistance. So that's a new kind of diabetes where you have type 1 as well as type 2. The features of type 2, that is insulin resistance. So obese type 1 diabetes may need more problem than a non-obese type 1 diabetes for the fertility. And that is why
Very
every
well said.
so it is
Go
really
ahead.
sorry, saying something, Purvi?
No, no, sir. Please carry on.
So in that manner, all three kinds of diabetes, type 1, type 2, and double diabetes, they are the challenges for a clinician, especially when they go to Uday sir, and that time if they ask for fertility, they are going to face problem. But before going to him, they should come to a endocrinologist or a diabetologist of their choice and try to get their all the parameters streamlined, achieve the fasting blood glucose to less than 90, postprandial blood glucose to less than 122 hours, HbA1c preferably 6, but if it is type 1 diabetes, even 6.5 is acceptable. If it is hypoglycemia is a big concern, then even you can accept up to 7% of HbA1c. But more or less, the message is up to 6.5 is acceptable for most of the women. When it comes to type 2, again, the glycemic parameters or targets before conception is certainly remains the same. Fasting 90, postprandial 2 hour 120, HbA1c 6.5, preferably 6. But they should but they should be on the safer drugs. So I feel we will discuss this little later. The message is very strong and clear that the blood sugar control can certainly bring, because I don't want to horrify the whole system that because you're diabetic you can't you have a baby. That is wrong message and it's a myth. If you control diabetes, so we talk other way around, Purvi, that if you have diabetes you can certainly get conceived, can have a normal pregnancy, can have a normal baby with proper glucose control and other parameters if you have associated disorders like PCO or other things. Over to Dr. Uday on this.
Great.
Yeah,
Thank you so much, sir. Please add to the response.
yeah. I think Sunil has really told us in a very nice and concise way what the problems the diabetic women have when they seek fertility, and the things they should be aware of when they are seeking fertility, and the male partner also who is a diabetic. Sometimes they are very worried about this, and they also sometimes have issues, which I think you're going to touch upon next, is the sexuality issues, because the males more often come with erectile dysfunctions because the nerves are affected, and then the erection is a problem, and having sex is a problem. So when we have a couple which comes to us for fertility treatment, we proactively ask the history of diabetes even in the husband, and we find out whether there is any problem as far as the sexuality is concerned. Now besides that, many patients are very worried ke, if we have diabetes, will our children have diabetes? Well, that for that we really can't pinpoint and say what genes, the genetic makeup, etc. But in pregnancy, like Sunita said, it is very important that the sugar should be well controlled, so that there is something known as in utero programming. The baby responds to the glucose levels of the mother, and if the baby gets programmed, then this baby can develop diabetes in future if the baby is subjected to a high glucose load. And this is what is important from the gynec point of view. And there is, in our clinical practice, the type 1 diabetics, they're so used to controlling the sugar well, and they go to people like Sunil or any endocrinologist when they're already under treatment, and they know the importance of controlling the sugar well, before becoming pregnant, and they generally follow all instructions because they are used to all that, and they already know how to use insulin, etc. The type 1 diabetics. On the other hand, the type 2 diabetics and all, sometimes they are a little reluctant, and we have to break the myths and tell them that look, in pregnancy it is important to have a very normal blood sugar. In fact, Before you become pregnant, the control of blood sugar is very important. Just Sunil has just elaborated. And for preconceptional control of sugar is extremely important for these patients.
That's a great point, sir. I just want to twist that question a bit and get some more information from you, Dr. Thanawala, sir. Is So, in your patients of infertility, what is the percentage of patients who suffer from diabetes, and which are the other striking features that one must look out for in terms of infertility?
If you ask me gross figures, I really don't have exact data, but if you ask me a general percentage of patients who have with diabetes, we have at least 4 to 5% of the patients coming in with an abnormal sugar. Some of the husbands are also having an abnormal sugar at a very young age, and that is what is very startling now. You've got 30, 32-year-old patients coming up with diabetes, uh, and that is what has to be looked into. And and believe me, these young people who are type 2 diabetics, sometimes they just take it easy. I mean, they really don't take care despite of like, oh yes, I'm on this tablet, and I said, what is your HbA1c? It is 9 or 10. So my job is to, of course, counsel the woman, make sure that she ovulates, make sure that she gets a good baby, and her sugar is, of course, under control or not. But sometimes we have to be after the husbands also, because recently uh, we delivered a woman who had come for infertility. Husband was grossly diabetic, and now when he came, he said, no, no, no. Now my sugar is absolutely normal. So I think no doctor should, whether it's a Dynac or any other doctor, should not miss a chance to
Yes.
address diabetes, even if it is in the partner who a gynec is not seeing the husband. I think it's the gynecologist's prerogative that he should be addressing the husband and telling them that life fine, your semen count is fine, everything is fine, but you must be you should have a healthy lifestyle. So you should take a chance, and I generally counsel both the people. If the husband is very obese, of course, I tell the PCO girl who's obese that you lose weight, but I tell the husband you need to get into shape, because I think it's high time we counsel everyone to get into a healthier lifestyle so that we have a healthier generation next.
So,
No, very
those were
rightly said.
some.
Yeah,
Yeah,
see,
sir.
Purvi, see, we discussed about female infertility, but rightly, Dr. Uday has said we should be also talking about the male their counterparts, because sometimes because of if they have diabetes or they have insulin resistance syndrome, even these men might have the problem with the maybe oligospermia, or maybe the different, despite having good numbers, still they might have problem with this sperm motility. And if husband is also diabetic, then if their blood sugars if not are not controlled, then there can be a problem with the quality of the sperms. The motility may get affected, as well as sometimes the count of the sperms that need to also be taken care. Apart from that, erectile dysfunction is one very important thing which he touched upon. Almost 50% of people with type 2 diabetes may have
Hmm.
partial or complete erectile dysfunction. Figure is very bad. 50%. We have proved it in our clinic, though not published, but even other data also says that 40 to 50% people may have. Of course, there can be difference between a psychological ED versus the organic ED versus the vascular ED. All these things can certainly be there. But then, Purvia, we should tell our audience that erectile dysfunction is not uncommon in men, those who are, especially those who are type 2 diabetes. And we should be aggressively, especially when someone is alcoholic, someone is smoker, again first further deteriorates their performance. Sometimes you are too obese and there is a syndrome which is called a buried syndrome. The penis is buried inside, a sperm count is normal, sperm motility is normal, female is normal, but because of lot of obesity, the penis is buried inside, and they can't have a normal sexual intercourse and normal penetration, which could be a simple cause of it, reduction of obesity, and possibly some other measures through measures can be taken care, and they should be all fine. But then these are few of the small areas where we need to work on. And erectile dysfunction, if suppose is there, then it's a very simple test we can think of. Do you have some question on erectile dysfunction? I'll otherwise stop here and then we can have
No, sir,
Purvi.
please go ahead. Please go ahead. Some very important points you both have made.
Now, erectile dysfunction can be sometime, many of the time, psychological. Maybe because of stress, maybe because of depression, maybe because of workload or other issues. Then, and it could be simple because of various other psychosocial disorders or psychosocial factors. The treatment is, first is we have to evaluate whether the person has organic or versus psychological ED. The simplest test which we say, of course there are multiple tests which can be done at a sexologist clinic, but a simple test which everyone can do it is a stamp test. A stamp test means they have to they have to just paste the postal stamp around the penis, and go off to sleep. And morning, if your stamps are broken, that means you have a early morning erection. Those who have psychological erectile dysfunction, they will have normal morning erection, which is physiological. Early morning, every one of us gets a normal erection that is called as physiological morning erection. Now, this is getting, if you it get hampered, then it is more likely to be organic. If your morning erection is preserved, it is more of a psychological one. But rather than going to a diabetologist or endocrinologist, people end up with those advertisements which are coming in the newspapers and others. The Shakti Badao, Takat Badao, Tel Lagao. All these things are too much kind of they actually misguide the people, and some of them these people they go to the those jadi booty wala things and all that, that actually is further causing more problems. And these things, the outcome will be zero, and they will spend a lot of money with at the cost of their health. So better, our people should know, if you have such things, come back to a doctor, consult them, and then take a proper treatment.
Great, great, sir. That was really some fantastic points. I think one, the fact that diabetes is affecting more people and younger people, that is one great thing to take care of, because that's what is going to further impact the issues of fertility. Next, 4 to 5% of our patients of infertility are all diabetic. We need to also take count of that. And then a very important phenomena you talked about, which was double diabetes, and that I think is not often again talked about, and it's just to highlight the fact that even if with type 1 diabetes, it's not like lifestyle changes or moderation in lifestyle doesn't need to be adopted, because that's again going to impact many other things, and that's probably the worst kind of diabetes that you can have. And again, the rising prevalence of obesity in our country. India used to be, is 70% rural and 30% urban, and yet the statistics always tell us that obesity is highly prevalent and just increasing in incidence. I think that also speaks of our changing lifestyles, the stress, and the increasing burden of infertility in our country.
Purvi,
And then the
diet,
fact,
yeah, Purvi, diet also plays a major role there. About
absolutely.
and important is what Uday has also commented on, that we are getting young people now between 20s and 35, 40s. And unfortunately, after this COVID-19, somehow we are getting more and more younger, newer patients. Suppose if I see my own OPD now, if I am seeing, say, 50 patients or 40 patients, out of 40, at least there will be, 20 or at least 15 of them. So 30% of them will be of young age, less than 40 years of age. If I see the onset, most of them will be 30, 31, or sometimes 28, 29. And that is why this young people, maybe male or female, are going to face these issues more often, versus, of course, the senior people who are coming to us after 50s.
Which makes this conversation even more relevant. So, with that, I would like to pose the next question to both of you experts. That we yes, and sir, you described male sexual dysfunction very well. It's still more commonly talked about than the female sexual dysfunction. It's almost like the female sexual dysfunction doesn't even exist. So, and we just celebrated the International Women's Day last week, and we touched upon several factors that can impact women's health. But this is also an important aspect of a woman's health and well being. And I would like to invite thoughts from both of you on this aspect.
See, Uday sir, should I start or you want to take over? Yeah. See, female sexual dysfunction, certainly Purvi is ignored entity in our population, but they are equally it is common. And we have seen in our own research, which was a questionnaire based research, that almost 35% of the female, they may have people with type 2 diabetes. They have women, they have sexual female sexual dysfunction. There's a survey, we just did it, yet to be published. So that is one thing. Second, what kind of female sexual dysfunction these women they get? One is, it is if your blood sugars are not controlled, you are likely to have dryness of the vagina. If you have dry vagina, the intercourse is going to be painful, and because you have a painful intercourse, it sometimes becomes difficult for the partners to enjoy the coitus, the orgasm. That's one. Second part is that if you have recurrent vaginal infection in female because of diabetes, because of uncontrolled diabetes, one is dryness, second is recurrent infection further causes fibrosis, and it becomes again difficult for them to have good quality sexual activity, at least the intercourse, and that again causes painful intercourse, and that ultimately it becomes a responsible factor or a triggering factor in these patients for the performance, because ultimately for once or twice failure or thrice failure, then they go into psychological issues and stress and depression. So this should be cut down through by using simple lubricant gels, good control of diabetes, control of the infection, then it becomes easy. Similarly, if your blood sugars are not very well controlled, or if you have associated comorbidities, then again these factors may get deteriorated further. Uday, you may add to this on these lines, please.
Well, generally, what happens is, like Sunil very rightly said, if you are prone to more vaginal infection because the vaginal mucosa is unhealthy, sometimes there is dyspareunia, painful intercourse, etc., which is elaborated. One can use lubricants to treat. But the most important factor, even for erectile dysfunction, what I tell my male patients is, or even the female patients who complain of these repeated vaginal infections, is keep your sugar under good control. And once your sugar is under good control, these side effects will reduce. The erectile dysfunction will reduce, because basically diabetes is affecting your the blood vessels of the penis, the nervous system of the penis, and that is where the problem comes in. So unless your sugar is controlled, you know 50% of your job will be done. And Sunil is so right in saying, don't get into those egg goli khane se, the erectile dysfunction will go away or something. Yes, go to an andrologist or go to a urologist or go to a physician or a diabetologist, and they will treat your erectile dysfunction. You can take proper sildenafil medicines rather than having something which is giving you some metals and all which may not suit your body and stuff like that. So it is important not to get misled. It is important, if you have a problem, to see. There are many therapies which people can give, for erectile dysfunction besides only tablets. So you must see a specialist and seek help. Unfortunately, sexuality is not really much talked about. So sometimes it is just people just stay with it. But I think it should be talked about, and it should be solved. And we have enough solutions. It's not only drugs. There are enough solutions available.
Very, very encouraging message, because I think the fact that women don't even consider this as a problem, they take it as a given. is not to be, further encouraged. And there is help. It's a scientific aspect, and we can reach out to our doctors to actually get help for that. So thank you. That was a great, great message. And with that, thanks for that. Very both of you have given us a beautiful overview of how diabetes impacts fertility and what are the different features that can be impacted. So after that overview, I would like to, we always want to talk about preventing a problem, and definitely, I think today it's well understood, but little practiced, especially preconception care. So with that, I request you both to, give us important pointers on preconception care, and I would also like you to comment on who exactly should be meting out that preconception care for our women today.
Now, the preconception care is basically those who are type 1 women who are planning their after marriage, or if they're planning their pregnancy, they have to, or a type 2 young women who are planning for their conception. So, first is that preconception, we should try to achieve first the preconception glycemic targets. Now, glycemic targets, as I told you earlier, fasting should be less than 90, postprandial 2 hours should be less than 120, HbA1c ideally should be less than 6. If not possible, at least less than 6.5 is best. If hypoglycemia is a major concern, especially in type 1 diabetes, you can accept even up to 7% in type 1, but not in type 2 diabetes. So once you achieve these your glycemic targets, then you should visit your diabetologist or endocrinologist, and then also get your other assessments done, which should be of your retina, that you should not have retinopathy, because if you have associated diabetic retinopathy, it will get further deteriorated as the pregnancy advances, and there can be a sudden vitreal hemorrhage or retinal detachment at the time of expulsion of the placenta at the time of delivery, and that can become a very horrifying situation, and person may lose their eyes. So in that situation, those women who have very severe PDR, proliferative diabetic retinopathy, or those who have earlier vitreous hemorrhage or something like this, that is contraindication for pregnancy. But that does not mean, as a common man, you should not perceive this particular message, that because your retina is normal, but because of pregnancy you will develop retinopathy. So important message, Purvi, is pregnancy doesn't cause development of any diabetic complication like retinopathy or neuropathy or nephropathy. But if you have diabetes, you are likely to have hypertension, preeclampsia, but that is again related to pregnancy. But if you have associated proteinuria before pregnancy, diabetic nephropathy, then even that can be deteriorated, if they are more prone to have hypertension during pregnancy. So that is, so if you have retinopathy, nephropathy, neuropathy, autonomic neuropathy or gastroparesis, which is another contraindication for pregnancy. Similarly, if you have associated coronary artery disease, or rarely you have cardiomyopathy, then that again becomes a contraindication for pregnancy, especially if you have LV dysfunction. Last but not the least, if you have suffered with any acute illness in last 6 months, then you are likely to be abstaining your pregnancy conception for some more time, and maybe you can go for conception after a year or so. So these are few important indications and contraindications for pregnancy, and preconception counseling is must. But unfortunately, 90% of the pregnancies are accidental pregnancies. I repeat, 90% of the pregnancies are accidental pregnancies, and they suddenly come to Dr. Uday or me or Purvi and saying, Dr. Sahab, galti se ho gaya. And that galti se ho gaya, that becomes a big kind of challenge for all of us, because by that galti se ho gaya, हमको ऐसी medicines रहती हैं which need to be stopped before you plan your pregnancy. There are statins which are contraindicated. Therefore, antihypertensive drugs like AC meters, ARBs, they need to be stopped before you get conceived. There are safe drugs to be replaced for blood pressure, safe drugs for blood sugar. There are many oral drugs which are contraindicated, and they, if the patient is already taking in type 2 diabetes, that again becomes a hassle for all of us. And by the time you diagnose pregnancy, it is already 6 to 8 weeks pregnancy. See, when your urine test comes positive, or when a sonography says you're positive already 5 to 6 or 7 weeks pregnancy, by 8 weeks of gestation, your baby is already पूर्वी. See, our people should know कि 8 हफ्ते का आपका जब बच्चा रहता है, तब आपका बच्चा पूरी तरह बन के तैयार हो जाता है. उसके बाद में उसका सिर्फ साइज बढ़ता है. उसका आईज, उसका ब्रेन, उसका स्पाइन, उसका हार्ट, उसके हाथ पैर, उसका लंग्स, एवरीथिंग, उसका इंटेस्टिन, everything is ready after 6 to 8 weeks maximum. If you just elongate for little more, then maybe it is up to 10 weeks. Everything is ready. After that, it is only the size of the baby which increases. And that is why during this period of organogenesis, if your blood sugar is high, and if you are on the drugs which are contraindicated in pregnancy, which may cross the placenta and may deteriorate the health of a baby, in that situation, we may face a big issue of compromising this pregnancy very often. So blood sugar control, vasculopathy to be evaluated, to be shifted to safe drug is important. Alcohol and smoking needs attention. Alcohol increases your desire for sex, but it reduces your performance. That is why if you are alcoholic, you might have a lot of urge to go for the sexual activity, but it may not give you good performance. Smoking again is one of the things which affects your erectile function. So these things should be strictly prohibited, especially in all type 2 diabetes and type 1 diabetics. I feel I have taken longer time than required. Uday sir, over to you.
Not at all,
I
sir.
think
Very
you covered it all.
Go
You've
ahead,
covered it
sir.
all very well. You've covered it all very well, Sunil. You've brought out all the points which should be done. So basically, I will tell you, it is probably the failure of the doctors also, because any patient, any doctor who's dealing with a type 2 diabetic or a type 1 diabetic, they should be telling these women who are in the reproductive age group कि जब भी प्रेगनेंसी प्लान करोगे पहले तुम्हारा HbA1c बिल्कुल ठीक होना चाहिए, नहीं तो प्रेगनेंसी प्लान मत करना. डोंट हैव अ अनप्लान्ड प्रेगनेंसी, यूज कॉन्ट्रासेप्शन. दैट इज द message we should be telling our patients, and that is why, and that doesn't happen. In spite of that, in spite of doctors telling them, yes, I agree, कि बहुत सारे पेशेंट्स हमेशा कहते हैं कि गलती हो गई सर, आई एम स्टिल प्रेग्नेंट. एंड व्हेन दे कम, द बिगेस्ट चैलेंज व्हिच वी फेस एज obstetricians or gynecologists is that if their HbA1c is very high, the risk of having congenital problems in the baby is also high. Now, there is also a myth amongst many doctors also, or many the general doctors also, अरे बिना बिना शुगर कंट्रोल के प्रेगनेंसी हुई है, HbA1c बहुत हाई है, 9 या 10 के करीब है, so then we should not go ahead with the pregnancy. Well, yes, there is a risk of malformations, but maximum risk of malformation is around 30%. 25 to 30% risk is there for malformation, but the other 70% of the babies may be normal. And today we have enough high-ended sonography machines to pick up any structural abnormality in the baby. Because these diabetics also, they take time to become pregnant. It's not easy for them. So if they have become pregnant, even with an abnormal HbA1c, we generally say no, wait, let us just do the blood test and make sure that whether the baby is normal or no, and then, if you want, you can continue the pregnancy. So important message here is that even if you're firstly, so don't get pregnant until your HbA1c is under control, because you put the baby at the risk of having some problem or some structural defect. But if you have become pregnant, there are ways to find out if the baby mostly will be normal or no. So that's why I don't even rush and think of terminating a pregnancy.
Great, thank you, sir. I think very, very clear messages from both of you, especially in terms of planning the pregnancy and also blood sugar control, besides screening for other complications and looking at the overall metabolic health as well, and getting ready to be pregnant. So that's an important thing. Again, I think preconception care is something that we all talk about, but what about the post conception care? If you can elaborate on a few important points for our audience, it will be very helpful. So with that,
See,
maybe
now,
we can start with the,
I
yeah.
think I
Yes.
think I'll go first, Sunil, because after delivery, then I'll send the patient to you. So you're talking about post delivery or post conception?
Yes, post delivery actually, postpartum.
Yeah, postpartum. So postpartum, in general, women who are even on insulin or who are on even drugs to control their sugar, because they have delivered, the requirement of the drug goes down drastically. So when they're in the hospital, Purvi, we manage their sugars, of course, by the glucometer. We see how much drug they require. Some of them who are on insulin may not require insulin again. Some of them do require insulin in a much lower dose. So that sugar has to be controlled at them. People who are only on oral drugs, sometimes they don't require the metformin at all. So if the sugar is remaining normal, we tell these women, and generally in the antenatal period also, they are doing self-monitoring of sugar, that when they get discharged, they should be doing their sugars. Breastfeeding is extremely important in the postpartum period because it helps to control the sugar also. Plus, it gives the best nutrition for this particular baby who's been born out of a diabetic. So, breastfeeding exclusively for 6 months is advised to them. They can get back to the normal routine within a week or 2 weeks, and in general, start doing some exercise and all. They need not be bedridden or lying on the bed. They should be starting getting the physical activity back so that the sugar can be controlled better. And they have to be aware that they have to do this blood sugar test, which they do now. If they're diabetic, of course, they do the self monitoring of blood sugar. But what we call GDMs, or women who have got diabetes in pregnancy, sometimes the sugars do become normal immediately after delivery. But they should be repeated after 6 months of delivery, and then once every year a glucose challenge test has to be done in a GDM patient so that they don't become frank diabetes, because many women who develop GDM, almost 50%, will become diabetes in the next 5 or 6 years. And if they have this lifestyle change, which is ongoing, then the risk of becoming a diabetic is very, very less. And of course, then we refer them back after 6 weeks of delivery to the endocrinologist for a better control of sugar, because now they can have many more drugs rather than the restricted metformin or insulin. Over to Sunil.
Brilliantly said. Thank you, sir. Thank you. And Dr. Sunil, what are your thoughts besides this immediate, control of sugars and SMBG postpartum? What are your thoughts on using metformin post delivery?
see, two important things. Let me finish up in very brief this Purvi. One is that
Yes.
if it is a type 1 diabetes, the insulin requirement, which has gone up almost 1.5 times or 2 times from the date of conception to delivery. Someone is taking, say, 40 units or 30 units of insulin before conception, may land up to around 65 or 70 units of insulin. So 1.5 to 2 times insulin as the pregnancy advances. The moment you cut the placenta, especially in the last week, after 38 weeks of pregnancy, the insulin requirement started going down. Once you cut the placenta, the insulin requirement of a mother suddenly goes back to less than 50% of the pregnancy, to the extent even lesser than the preconception days. So before pregnancy, whatever their dose was, usually 15 to 20% less dose these women with type 1 diabetes require after delivery, at least for a few more days. Type 2 diabetes, if they're already on insulin earlier, again the same story will be repeated. But those who are GDM or those who are type 2 diabetes on oral drugs, GDM women, as rightly Dr. Uday said, around 15 to 20% of the GDM women may remain hyperglycemic after delivery. So if you have 100 GDM women, 20 of them or 15 of them may remain hyperglycemic, and they may need diet therapy or pharmacotherapy. About those who are type 2 diabetes, they again want to go back to tablets. But during the breastfeeding, the best treatment is insulin therapy. I will avoid giving any oral drug, but if we have the safety data available for three oral drugs, one is metformin, second is glibenclamide, and third is gliclazide. These three drugs have been shown that the excretion in the milk is minimal, and is not significant to causing any problem to the baby. But still, insulin becomes a drug of choice because it does not get excreted in the milk of a mother, and that is why we prefer this. Rarely, but if women doesn't, the mother doesn't want at all the insulin therapy, metformin becomes a choice for us in India, and other drugs we are not using so often. But we have to be careful. There is no safety data available for glimepiride or gliclazide or glitazons or gliptins or gliflozins. So please don't use these drugs during the breastfeeding, because it might come out in the breast milk and it may go to the baby through the breast milk. Breastfeeding is directly proportional to the prevention of metabolic syndrome and obesity in the mother and development of diabetes in future. Longer the duration of breastfeeding you have, higher is the chances of preventing yourself from diabetes. So every woman should be encouraged to go for breastfeeding for as long as they can. Even it is beneficial to the baby, as Dr. Uday has already commented on. Thank you.
Excellent overview of how to manage a woman postpartum also by both of you. It was very enlightening, and I would request a final message from both of you on this aspect of diabetes, pregnancy, and infertility.
Let me
Uday
ask
sir,
this.
would you like to go first?
Well, I think Sunil is very good in giving out these messages. But well, if you're asking me, I will tell the general public that diabetes is, if you have diabetes, well, you have to live with it and you have to live fully with it and keep that diabetes under control so that you can have a full life and a problem-free life. Because so many patients, especially like the young husbands I talk about, they don't realize it because it doesn't do a damn to you. It doesn't have any symptoms. It doesn't tell on you even if your glucose is very high initially, and gradually you have to be aware that this high sugar is going to affect your retina, like Sunil has said, it's going to affect your kidneys and it's going to affect your heart. So unless you control the sugar, it's going to be a problem in future. So get that diabetes under control by whatever means, and then your reproductive life, your pregnancies, and everything is going to be smooth if you keep your sugars under control. And if you go to a person like Sunil or any so many diabetologists, they will give you so many ways of controlling the sugar that it's not very difficult to do. You should have the will to do it and control the diabetes and move ahead.
Brilliantly said, and that was wonderful. Let's hear it from Dr. Sunil sir now.
Purvi, as a public awareness program, I would like to declare and tell it very authentically that practically every woman with type 1 diabetes or type 2 diabetes without many of the comorbidities can get conceived. So don't get disappointed that you have diabetes so you can't get a baby. That's first message. Second, every mother as well as the father has an apprehension that if they have diabetes, their child will also develop type 1 diabetes. The risk of this is less than 4% a year, so don't worry about it. 96% chances, even if both parents are type 1 diabetes, the chances is not going to be bit more than 10% or so. So the risk of developing type 1 diabetes, मेरे बच्चे को जन्म से ही diabetes हो जाएगा because I have got diabetes, is a wrong perception amongst these couples. And that is why we should tell every woman that not don't worry about it. You plan your pregnancy, but of course systematically, as we have told, with following all the discipline. And if you control your diabetes very well during the pregnancy period, टू दी एक्सटेंट कि बेबी को मालूम ही नहीं पड़े कि आपका डायबिटीज है। उदय सर के जब भी बैठे रहते हैं तो वो डायलॉग मेरे को याद आ जाता है हमेशा। आई ऑलवेज कोट वेदर इज देयर और इज नॉट देयर, दैट ही लाइक्स दिस कोट बिकॉज he has quoted this particular statement of mine practically everywhere whenever he talks about gestation diabetes. Uday sir, thank you very much. The quote says, if the glycemic control can be maximized, I repeat, if the glycemic control can be maximized to the extent that the fetus do not recognize that the mother is diabetes, that can be the first step towards the prevention of diabetes in the offspring of diabetic mother. सच ए वंडरफुल डेफिनेशन कि आपके बच्चे को मालूम ही नहीं पड़े कि मदर को डायबिटीज है। इतना अच्छा शुगर यदि हमने कंट्रोल किया तो हम इन बच्चों को आगे जाके आगे की जनरेशन वालों को इन बच्चों को उनकी एडल्ट लाइफ में डायबिटीज से बचा सकते हैं, विच इज कॉल्ड एज प्राइमोडियल प्रिवेंशन. So with these three messages, I feel I have summarized everything, and hopefully we all should be becoming very positive in this area of medicine. That diabetes, don't. I never call diabetes a disease, Purvi. Uday sir, for you also. I don't say it a disease. It's a condition. It is an accident which has happened in your life. It's okay. Accept it. Yaar, kya problem hai? Accept it and move on. Move on. What you said.
Like COVID.
And yeah, don't worry about that you have diabetes. So that's what possibly that's the only message, Purvi, I could give at this moment of time. You can certainly conclude and have some more addition in cream, because I know your English is much better than mine. Thank you.
Sir, that was absolutely brilliantly conducted. I cannot be more thankful. We had the best of both the worlds today, not only from the field of diabetes and medicine, but also from the field of obstetrics and gynecology. So I am just overwhelmed that we have never discussed this on RSSDI Diabetes Bytes. This is the first time, very first time, that we've had this aspect of diabetes and infertility and pregnancy being discussed on a patient education forum. So I remain personally, as well as on behalf of the entire RSSDI national team, on behalf of Dr. Vasant Kumar sir, on behalf of our national secretary, Dr. Sanjay Agarwal sir, the entire EC, and that constitutes also you, Dr. Sunil sir, and the social media team. I'm immensely grateful to both of you for sparing time. Dr. Uday sir, I know both of you are still at the clinic. So we are thankful for taking this effort and making our patients and audience more aware of this aspect of reproductive health that we all must, that we must face. And then those with diabetes need not lose heart. Your messages and your take-home messages for the patients were extremely encouraging and reassuring. So thank you again for that.
Before we conclude, I feel we should give homework to our people, those who are listeners. Without homework, how we can just teach people without giving them homework? Any classroom should be having a homework given to listeners. And my homework to every one of you is that, see, 10th of March, we are celebrating National GDM Day. So we usually when we have Valentine Day, we remember our Valentines. When it's a Women's Day, we remember women. When it is Father's Day, we just celebrate Father's Day. Anniversary, we celebrate anniversaries. I feel every day should be celebrated. Every day should be giving some messages to on these lines. So you, if you are a good listener, you can also become a good educator, taking these messages in a very positive way, so that you can reduce the sufferings of many who have not heard about it, or who have such kind of misconceptions in their mind. So it is not just you should just listen, but you should also share these positive thoughts in the society to become a good diabetes educator at your end. Not necessarily you should have a certificate. That's what is the main motto of Research Society for Study of Diabetes in India. That's what is the vision of Dr. Bansi Sabu, who started it, and Dr. Vasant Kumar and Sanjay is still continuing it. I feel, and the team of this social media task force under Purvi's leadership. So I feel our vision is not that Dr. Purvi needs some popularity, or Dr. Uday, despite having so much seniority and so much dedicated academician and a obstetrician of the whole country, is still sitting here for education of people, or any one of us. So please don't underestimate the presence of these dignitaries. Please take good quality messages and spread around. People should know about these ailments to simplify their life, remove the myths from their mind, and make their life stress-free. I feel that will be your homework for the future. Thank you very much, Purvi.
Excellently summarized, sir. We couldn't be more thankful, and that is great homework. I think this is the whole message, that this needs to be a ripple effect, and people need to spread this information and education further. So, with that, I take this opportunity to thank you both once again, and we will rope you in for further efforts from RSSDI. Please be there for us even at that time, and we wishing you a great holy or festival times. And thank you so much for being here.
Thank you, Sunil, and thank you, Puri, for having me on the show. Thank you very much.
Thank
Thank
you,
you,
sir.
Dr. Uday, and thank you very much, Purvi. Wonderful, and congratulations to the whole team. Thank you very much. Really
Thank
enjoyed.
you, sir. On
We started
yes,
for
thank you.
7 to 7:30, but I feel we have ended up.